as was mentioned before, is this idea of mistrust. Many of you have heard this. Many of the main problems is just people not trusting the healthcare system for a whole host of reasons. I threw this in just very quickly. This is from a Kaiser study in 2000 where they asked a series of patients if they thought they've been treated unfairly in the past. And you can see the difference between the black, whites, and Latinos. But the part that I found fascinating is when you ask them for the future if they thought they were going to be treated unfairly, even more folks thought they were going to be treated unfairly. Then if you superpose that on top of the fact that if you ask most physicians, they'll tell you that there's nothing wrong with the way care is provided in the healthcare system. So now you're dealing with two different perspectives and some really fundamental systems change, behavioral change issues that you've got to get down to. All right, so let me jump to the strategy form. So the Disparity Solution Center was created in 2005, actually built on the IOM report. Specifically, we focused on health and health care, specifically health plans, hospitals, and community health centers. But we had decided that wouldn't it be interesting to think about how to come up with some innovative strategies to address disparities? And how do we take it outside of the typical choir? How do you take it outside of the folks that normally just talk about health disparities? And what we did was we convened 20 experts across the field from what we call the organizational excellence. So this is the folks that do a lot of work with the Baldrige criteria and the Baldrige Award. Do folks know those? Yeah, okay. But don't necessarily do work in disparities. But thinking about, is there a way to look at awards or getting organizations to compete to improve disparities? Then there is the quality improvement field, which I mentioned is gaining a lot of interesting work around improving healthcare for all to address disparities. Then there's this idea of implementation research. This is a field where is growing more and more, relatively new, but the idea of how do you take an intervention that's research-based and then actually implement it in a clinical scenario. And actually now NIH is supporting a lot of funding around this. They're calling it translating research to policy and clinical environment, because what's happened historically is that now we have all this great research that's done, and then you have all the policy workers and the clinical workers on one side, and then never the two shall meet. And if you look at some of the data, it's disheartening to see that it actually takes about 17 years for a research discovery to actually get to the bedside. So this is a whole new field that's coming up. So we brought a bunch of folks from there. And then the folks that are currently doing work around racial and ethnic disparities. And the idea was to think about innovative strategies for modifying systems, processes of care, fostering organizational development and excellence that would help to reduce disparities. Also, we're trying to think about what are the new insights about possible interconnections between the fields. One of the things we've come to realize, as all of you clearly here to demonstrate, is that if we're going to address disparities, it can't just be folks within a hospital and folks that are looking at health disparities. We've got to start crossing boundaries to other fields where we could either learn interesting methodology, learn different ways of approaching this to help us think innovatively about how do we address disparities, since it's such a complex and multifactorial issue. Then the third thing we were trying to do is begin to develop a set of guiding principles for addressing disparities in innovative ways from the four fields. So I'm just going to quickly go through these. And the truth is, we do some of this in our Disparities Leadership Program. We do it over 2 days, so I'm trying to squeeze it into about 20 minutes. So I'm actually going to... Okay. Can't take my time. So I'm going to actually focus on 3 areas in particular. And I focused on these 3 because in some of our work with hospitals across the country and health plans, we found that these are the 3 areas that folks are most grappling with. And probably these are the areas that need to be most focused on. So the first is simple enough, getting buy-in. Not buy-in from the folks that are already part of the choir. Buy-in from the folks that aren't here in this room. Legislators, policymakers, organizational leaders. How do you get them to start to say, oh, health disparities can have some impact on what we do. We need to pay attention to this and get involved. The second area and the third area that I want to focus on is the idea of data collection, and then the idea of developing disparities measures and reporting. What we found was, as we started developing these innovative ways of thinking about disparities, is that the simple truth is people sometimes weren't even collecting the information to see if there was a disparity that existed. And what we found was when you start to, and I'll talk more about this, when you start to delve into this, there is still a lot of work that needs to be done. And the truth is, wearing my hat from my days as a Fed, if there is no data, there is no problem. And the reality is people will sort of say, well, we'll get to that. But until you actually have the data to demonstrate why you're allocating resources there, why should this be a focus, what impact this has, and whether you're actually making a difference or not, then you really aren't going to be able to get this off the ground. And it ties in nicely with the idea of getting buy-in. So, securing buy-in. Making the case to leaders that they need to take action. And I use the word leaders loosely. And I'm not talking about just hospital CEOs, but I'm talking about sort of the broader gamut of people that can have some kind of impact on improving health of the population. And again, I'm not just talking about folks within, say, Health and Human Services, but people that may be working in the Department of Labor, folks that might be working around employment issues, folks that might be working around social service issues. All those are leaders that have something to bring to the table. So what we've kind of framed it as is that there are kind of four basic cases. There's the ethical case, the quality case, the business case, and the legal case. I won't go through each one. But if you're interested in learning more about this, we've built on this and with the support of Roderick Johnson, developed a guide for hospital leaders to think about how do you advance disparities within your institutions. And within that, we go through these four cases. And we give examples of hospitals that have done it. So just the simple ethical case, as many of you know, is the idea that we need to address disparities simple on a moral imperative, that it's just not morally and ethically appropriate for populations to have different quality of care and health outcomes. But what we've realized is, depending on your institution, that doesn't always work. You may have an organization that's very business-driven, and you have to make the case to them that, well, if you don't necessarily address disparities, here's the impact on your bottom line. If that's what it takes to get the board of trustees, the board of directors, the hospital CEO, the health planner, whatever it takes, you've got to figure out how do you frame the argument of disparities so that people can actually hear it in a language that they can connect with. And so we found from some of our work for this Guide for Leaders that the quality case has a strong toehold for folks. Actually, Seattle Children's did a wonderful piece where they were curious because they kind of heard that some of the minority populations had different thoughts about the hospital. And so they began to try to explore it. But it wasn't until a fellow, actually a pediatric fellow, came in and said, well, let's look at if there's a difference between people that speak English and hospital error rates. And what they found was that if you didn't speak English, you had a much higher hospital error rate. That simple fact was all it took to get the hospital jump-started. The board was all involved. They were involved before, but even more involved now. Hospital leadership was totally committed to it. They created a Office of Diversity. They brought in a chief diversity officer. It started all this chain reaction of different things. So I bring that out as an example to think about what is the case that you need to make to get those hospital leaders on board. Because what I found from giving this talk is very often people will say, well, why don't they get the moral imperative? Well, that might not be the way that they need to hear that information.